So antibiotic resistance, it's a worldwide problem. Why the heck should we try to tackle it at a local level other than just out of the goodness of our heart, altruism, trying to make one small drop in the bucket? Well, it turns out that local resistance patterns actually correlate quite strongly with local outpatient antibiotic prescribing rates. So this is a an issue that plays out on a local level to varying degrees, depending on whether people engage in appropriate or inappropriate use of antibiotics. So this really creates an imperative to act at even at the practice level, at the community level, and to reconsider our policies and how we go about our prescribing. This graphic here is doesn't necessarily relate those two things, but it's just meant to show the wide variability, even within the United States, of antibiotic resistance. This map would look a lot different, probably for some different organism. It's CRE here in this case, but just that it really is a local issue in that it is that fine grained. It does vary from state to state, region to region, community to community. So I would really encourage primary care practices to consider whether delayed antibiotic prescribing for RTIs is something that they would consider becoming more intentional and systematic about. Um, and that is actually one of the key reasons behind this video is to try to encourage buy-in or at least uh, interest or questions about what is delayed antibiotic prescribing and will it really work? Um, so I would suggest as a pilot project of sorts that members of a primary care practice meet, determine if it's a strategy that they're willing to employ for pharyngitis and acute rhinosinusitis, and come to some consensus and an action plan. Now, I would propose getting a baseline of data on antibiotic use before anything were implemented. So in year one, um, what I would recommend is since antibiotics are prescribed more frequently in the winter, I'd record how many prescriptions were ultimately filled by patients who presented to the practice with either pharyngitis or acute rhinosinusitis from December through February. And I would presume that within 2 weeks of presenting to the office with that illness, would be enough time to really determine whether or not they filled an antibiotic for that illness. So this would be accomplished by double checking with area pharmacies. This could, um, a research assistant could be useful for this, or possibly a pharmacy technician. They're doing that all the time in emergency departments, calling, following up, trying to get accurate med lists for patients and to see when the last time they filled medication X was. So, if it were possible to recruit a pharmacy technician to be part of this team, I think that would be very useful in helping establish a baseline. So after this 3 month baseline of antibiotic use rates is established, in year two, same thing, December through February. So in December, start the intervention. Once again, only for sore throat and sinusitis, and use the ACP CDC guidelines for antibiotic selection and the UK NICE guidelines, National Institute for Care and Health Excellence guidelines, to determine the length of delay in each situation. If possible, have the patients return to the clinic or office to pick up the prescription, and educate the patients using the CDC information sheet and reinforce what we know about most RTIs and that most of them are viral. We'll prescribe the appropriate antibiotic and then give them advice on appropriate symptom control. So next, we'll look at the data. We'll record antibiotic use again by following up with pharmacies. We'll verify the prescription fills for 3 months. We'll record the total number of fills for pharyngitis and sinusitis-related symptoms, as well as data, breaking down the data for immediate versus delayed prescriptions. Because remember, they'll probably still give some immediate prescriptions. If someone is very clearly presenting with strep throat, if they're rapid strep positive, we're going to start treating them. So we will record that data and then calculate the fill rates as percentages. So we can get an idea of the percentage of people that use the delayed prescription, how many of them use their antibiotics, how many of the immediates use their antibiotics, and how much of everyone else used their antibiotics. Also record any bacterial complications if they are present. Again, this is rare, but we want to see if we notice any big spikes in any sort of complications. And then analyze the data. Did the antibiotic use decrease in year 2 compared to the year 1 baseline? And then, as a provider group, come back together and discuss your subjective experiences of the process. Was there a lot of patient resistance? How did you feel about it? Was it too time consuming? How did the workflow go? And this will be very important in deciding whether it's something that makes sense for your practice going forward. So a few considerations when contemplating whether to pursue such a pilot project. The first one being, is it research? Meaning, is it meant to create generalized knowledge? Or is it a quality improvement project where you're using best practices and just implementing them and hoping that that will improve certain metrics, in this case, lowering antibiotic use? So if it is deemed research, it may come under some more scrutiny. It may need approval from an institutional review board. Participants may need to provide their informed consent. So that is a consequential distinction in thinking about how you plan your intervention. I would think it would most likely fall under quality improvement unless people were trying to get published. So speaking of getting published, it may be useful to partner with a university. They have grad students who have to and want to do research. It may help leverage research funds and other resources, resolving some of those institutional review board questions. But again, it could sort of tip things towards the, okay, now it's research side of things, and therefore, again, that requires a little bit more red tape and oversight. So that's certainly an issue to think about. And finally, regardless of whether it's research or quality improvement, great care needs to be taken to de-identify personal information, protect patient privacy throughout the entire process. Some barriers that need to be addressed if we undertake such an intervention. First of all, cost. Fortunately, it's a low overhead intervention, but there will be costs associated with collecting and analyzing data. Next, there may be provider concerns about patient satisfaction. Hopefully, these concerns can be assuaged by going over some of the research that really shows that there's not much of a difference in patient satisfaction between using immediate antibiotics and delayed antibiotics. There may be some patient resistance, but again, with clear instructions and education, hopefully that will be minimal. Another complicating factor is that most prescriptions are now electronic, so the act of delaying becomes a little more complicated. So you need to coordinate with front desk staff and pharmacies to create a delayed prescription redemption process that works for that particular outpatient practice. There may be a means of establishing sort of a fast track line at the front desk where people can come in and just say, they'll be on a list and say, hey, I'm so and so, I have a delayed prescription, and then front desk staff could quickly alert a physician and they could send the prescription through. But again, it just becomes a little bit more complicated when it's not just a written prescription. And then finally, time. Primary care offices are really busy places, and educating a patient about a delayed antibiotic prescription takes a lot longer than just writing a prescription and saying, "Yep, here are the instructions. Take it, according to the pharmacy instructions. And there you go." No, it involves trying to help the patient actually understand the clinical reasoning behind their treatment. So um, that, in my opinion, may be the most significant barrier to implementing such an intervention.